So, hi everybody. Est-ce que ça marche? Hello. No. Good morning, everybody. It's a pleasure for me to introduce this symposium on the use of neuroimaging to reveal changes that are induced by cognitive training or different kinds of intervention. And we are going to have three speakers, Benjamin Hampstead, myself, and then Benjamin Boller. So let me introduce you first, our first speaker, Benjamin Hampstead. Benjamin Hampstead has done his training in Emory, Atlanta, and is now a professor at University of Michigan in the psychiatry department, and is really doing fabulous work in neuroimaging, but particularly in cognitive training with all kinds of approaches, including TMS. Is going to talk a little bit about that, and is really a rising star, or maybe is already quite high. And that, for instance, he was awarded the INS Early Career Award in 2016, which recognizes his contribution to the field. So he's going to talk about tailoring memory training using functional neuroimaging, neuroanatomy.
Thank you. All right. Well, thank you for that great introduction. It's really a pleasure to be here, and I really want to compliment you all on really a tremendous center. I've been very impressed with the breadth and the depth of the research, and I think it's a really unique resource that you have all of these colleagues, and while everybody is doing their own line of research, it's a great atmosphere to exchange ideas and to get feedback that I suspect has really benefited many of you. And so I'm just want to say thank you, especially to Sylvie for inviting me. Sylvie's played a large role in helping to shape my own line of research, so thank you again. And as you can see, I'm going to be talking about some neuroanatomy and how we can use the functional neuroanatomy and really take fMRI from a tool that traditionally developed as more of an observational measure and really use it to think about how we can both then select interventions and then measure outcome. I have no conflicts of interest. I want to acknowledge my funding agencies, especially the Department of Veteran Affairs. It's funded a number of works that I've done, as well as the NIA, and especially acknowledge our Alzheimer's Center at the University of Michigan, down here. Very briefly, I know that, again, given that everybody has their own line of research, I know it's all focused around geriatrics, but I like to just do a very brief overview of neuroanatomy, because I know various people have differing levels of comfort with that, as well as with MCI and Alzheimer's disease. And I have the benefit of following a wonderful session that gave you a lot of insight on MCI and AD, so I can kind of skip over that. I'll talk about some of the work that we've done with these cognitively oriented treatments, and specifically some rehearsal-based approaches and contrasting those with more approaches that rely on mnemonic strategies. And as Sylvie mentioned, then I'll wrap up and tell you about some of the current work that we're doing with transcranial direct current stimulation, both on its own and alluding to some work that we have ongoing where we're pairing the cognitively oriented interventions with then TDCS. So I know everybody, when I said neuroanatomy, I know everybody is fired up. They're very excited to get to look at the brain and think about the brain. So just in case you're not one of those people, here's a very basic overview. So here is an average head. If I give you X-ray vision, obviously we have the brain inside. The brain is obviously critical for everything that we do, and the brain has four primary lobes: the frontal, the parietal, the temporal, and the occipital. What I want us to focus on, and this is as deep as I'll go, I promise you, is this lateral frontal parietal network that we know is critical for cognitive control. Things like working memory, strategic planning, some of the inhibitory control that we talked about in the last session. So just remember this lateral frontal parietal network, and one other region I'll mention is the hippocampus. I'm sure many of you know of the hippocampus, and I've again made the brain now see-through and tried to highlight there in green, and then down here I've removed one cerebral hemisphere so you can see the hippocampus and where it is. We know that the hippocampus is absolutely vital to learning and remembering new information. There's emerging evidence that it's also very critical for remote knowledge, and especially the episodic elements of our autobiographical memory. So hippocampus is critical. It's one of the areas that's affected very early in the disease course of Alzheimer's. We know that the hippocampus then interacts with this frontal parietal network in order to enhance our learning and to form successful memories. And I'll show you some evidence that I think will support this, and then lead us to the main premise that we can target these particular networks a couple of different ways. We can either avoid it or we can try and re-engage it. I don't have to tell you all that memory changes with age. We know it becomes less efficient. There's reduced strategy use, and this may be underlined by some changes in hippocampal subregions, just as a part of normal aging. We know, based on multiple different approaches, that there's a shift in activation in more posterior focused and younger adults to that drops out with normal aging, and so there's this posterior to anterior shift that I think our previous speakers talked a bit about with some of the P300 or the amplitudes. So we know that other studies have found increased functional connectivity between that prefrontal cortex, that lateral frontal parietal network, and the hippocampus, and that this is often interpreted as compensatory in nature. So basically the brain is trying to adapt in order to help us maintain our cognitive functioning as well as we can for as long as we can. So these are quote unquote normal age-related changes. And I emphasize this because anytime we talk about Alzheimer's disease or another age-related condition, those effects are superimposed on these normal changes. And so you have to keep that in mind when we're interpreting data, and especially as we're thinking about restorative versus compensatory mechanisms. And so it pretty quickly gets fairly complex to understand that. Again, going back to these deficits and how Alzheimer's disease superimposes on that, we know that Alzheimer's disease, as we heard, is characterized by learning and memory deficits, as well as aspects of language and even executive functioning. Those are the most common presentations, but of course, patients vary. They can have different patterns of deficits, and a lot of the times, the extent and severity of these deficits depends on when they present clinically. Mild cognitive impairment, as we heard, is this transitional stage that the person shows a decline relative to their historic levels, but they haven't progressed to be severe enough to be considered Alzheimer's type dementia or another type of dementia. And so it's really meant to be this gray area where, again, as we heard yesterday, traditionally, it's been viewed that there are primarily just cognitive deficits, especially in the areas of learning and memory. But as the group presented yesterday, some really wonderful work showing that there are, in fact, some functional deficits that emerge even at this stage. We know that Alzheimer's, in the general population, again, population level, individual patients can vary, but typically Alzheimer's progresses in a known pattern, starting with medial temporal lobe structures for both beta amyloid and for neurofibrillary tau, that begins with medial temporal and limbic structures and progresses until virtually the whole brain is encompassed in the very severe disease stages. As I mentioned, we know that the hippocampus is affected, and this is a study that's now 20 years old that Jack and colleagues kind of were among the first to nicely demonstrate that compared to healthy, cognitively intact older adults, those with Alzheimer's disease show significant atrophy of medial temporal regions and especially the hippocampus. So that's the extent of the overview. Just wanted to get everybody on the same general page. And so when we think about the pattern of disease progression and the pattern of cognitive deficits and the neuroanatomical changes, we have a whole host of possible intervention techniques that we can use. And this comes from a review that we did, I guess now about 3 or 4 years ago, where we really looked at what techniques had been used for memory training purposes or memory intervention related purposes in those with MCI. And at that time, perhaps not surprisingly, there were almost as many reviews on the topic as there were original studies. So we were just getting more and more reviews of the same studies. And so we stepped back and really looked at a methodologic approach, agnostic to outcome, and tried to identify a number of factors that really could affect our ability to integrate that and inform future directions. And so this was one of the, I guess, schemas that we came up with, where we tried to group these general approaches based on the underlying mechanism of action, so to speak. And so again, there's certainly can be some debate, because a lot of times you'll see that we use rehearsal while training patients to use these techniques. But the bottom line with rehearsal-based approaches is really that we have the idea that practice makes perfect. You keep repeating information and you help the patient learn the information progressively over time. How you structure that information can be a little bit different. I'll give you a couple of examples with that, with spaced retrieval and vanishing cues. We all know that calendars and notebooks and lists and smartphones, those are all tremendously helpful. We all rely on them, and so it's not surprising that our patients can benefit from them. So I'm not really going to talk about these external compensatory approaches too much. I'm going to spend a lot of time talking about the mnemonic strategies, which help us to better organize and structure the information during both the encoding or the learning process, as well as subsequently then when we need to remember it. And I'll again go into some detail here in a minute. Bottom line is that I believe that the technique really matters, and that individual differences, I don't really touch on this too much, but it could be a good conversation for all of us to have at the end. Individual differences in just people's preferred processing styles, as well as disease severity, may dictate which approaches we use. And so we may need to shift from early in the disease course using some techniques to then other techniques later in the disease course. So I'm happy to come back to that point in a little bit. We've tried to use ecologically valid paradigms, and so we've developed a number of these paradigms that our patients complain of difficulty with. So face-name association. So a lot of our patients complain that they're withdrawing from social activities because they can't remember people's names. That leads to the social isolation, depression, on and on. So we wanted to try and develop these paradigms to evaluate these things. So we have the face-name associations, object location associations. This is a very common complaint for a lot of participants, misplacing objects, as well as spatial navigation. I'm going to spend most of the time really talking about this object location paradigm. Again, starting with more observational-based research and between group comparisons, and then leading into the intervention work. And object location associations are kind of nice because Postuma and colleagues built on the seminal work of Mishkin and Underleger and colleagues, really where Mishkin and Underleger had that ventral and dorsal visual stream. And so Postuma and colleagues integrated that, but also extended on it. And so when we think about how we remember the location of objects, the first critical step is really knowing what the object is. And so that activates this ventral visual stream area. So we have to know what it is we're trying to remember its location. The spatial information, again, we know involves that dorsal processing stream. But where Postuma and colleagues differed a little bit was that in addition to that spatial information, you have to engage that lateral frontal parietal network that I mentioned earlier in order to hold the object and the spatial location in mind until it's able to be bound into a memory by the hippocampus and medial temporal lobe structures. Okay? So this gives us a nice testable model in a problem that many MCI patients and all patients with Alzheimer's disease have a very hard time with. And so we can use this model to test where the patients are falling down, so to speak. So our paradigm, in this first study, we used a slow event-related design where we would show an object, in this case measuring cups, and then we'd show the location of the object within a realistic enough looking room. Now, I'm no interior designer. I've had students come along and modify a lot of these to make them far better than what my skills were able to do. But the idea is pretty clear, that you can see keys that are in the living room and so on. And so we would have participants or healthy controls and MCI patients do this task. We tested Postuma's model directly in a paper with one of my postdocs a couple of years ago, where we isolated just those object-only portions of each trial. So we just show them the object, and sure enough, we see that ventral visual stream activation. I would have been very concerned if we didn't see that, so check. We then isolated the object in location phase, so that picture with the room and the object located in it, and you can see that we're getting very robust ventral visual stream. We're getting the frontal parietal activation, so check, check. And now in this phase where they have to bind this information together to form a memory, we're seeing extensive medial temporal activation. So again, that's wonderful. So that partially supports it, but what we wanted to do is really look at the working memory component. So we used a standard end-back paradigm that I'm sure many of you are familiar with, but the general premise is that you show a series of stimuli and you ask the patient to identify when a stimulus was the same as the one that was seen 2 stimuli ago. So it requires the online maintenance of information, just as we would need with remembering the object and that location. So you can see that we don't see any ventral visual stream activation here. We don't see any medial temporal. We see purely that frontal parietal network. Again, check. I'd been very concerned if we didn't see that. We then did a conjunction analysis between the working memory and the object in location phase. And so there, again, we pull out just this frontal parietal cognitive control network. So again, note that we've been able to really isolate that this medial temporal activation is only during that binding process. And we show some beta weight graphs from various ROIs that again really support that in that paper. So that was in cognitively intact young adults. So we know that our paradigm is doing what it should. And so when we then compared MCI patients to cognitively intact older adults, not surprisingly, the MCI patients performed significantly worse. When we matched the trials for correctly encoded stimuli, so we made sure that we were comparing apples to apples, MCI patients, again, not surprisingly, showed bilateral hippocampal dysfunction. Again, I would have been concerned if we didn't see that. We know that it's dysfunctional, and so we see it. What was very interesting, though, was that we also saw these lateral frontal parietal, the cognitive control network, was reduced. This led us to then collaborate with a colleague, Gopi Deshpande, who is really kind of a connectivity guru. And so we extracted time course data from a large number of ROIs that were active in both MCI and healthy controls during both memory encoding and retrieval. And we sent the data to Gopi, and he worked his magic, and he sent back results that are here. So I focused just on the encoding process, so the learning process. And so Granger causality relies on the temporal precedence. And so really what you're doing is inferring that activation in one ROI led to activation in another ROI. And so he has a series of analyses that he uses to parse these out. What you can see with healthy and cognitively intact older adults is that there were 3 primary regions where you can see a lot of lines emanating from. Those are known as drivers. So these were the critical areas that were driving activation in other brain regions. The interesting thing here is that these are part of the frontal parietal cognitive control network. I don't have to tell you that the MCI patients were substantially different, right? You see one primary driver, that was in the right frontal eye fields. We know that this area is involved in attentional saccades. And so it suggests, it kind of lends credence to these earlier just contrast-related results showing that MCI patients are losing that ability to engage the top-down cognitive control. And so that has direct ramifications when we think about the interventions and what we can do. So in this study, we randomized a total of 58 patients with MCI to either mnemonic strategy training, again, the top-down cognitive control-related training, with a spaced retrieval training, which is more of a rehearsal-based training that we know is effective even in patients who have progressed to Alzheimer's. You can see that the bulk of the patients were able to complete fMRI. And one thing that I'll highlight is that we've completed 4 different studies, 3 of which are single-blind RCTs, all with the same general results. And so you'll see that a lot of the work that I'm presenting is in progress. It's one of those that it's on my desk. It's various stages of written up. And so by the time it's published, the results could change a little bit, but we're seeing the same general results over and over again. And so again, we can ask, our strategies, because presumably they engage that lateral frontal parietal network, are they more effective than spaced retrieval, which should rely on more implicit priming, which we know is also intact in Alzheimer's, and that may be a way of working around the areas of impairment in these patients. And then do the techniques, is this difference reflected in the patterns of activation that we see? So again, the mnemonic strategies that we use, same general approach with each of the studies that I referred to. Here what we've done is a very mechanistic-based study to, again, really understand the mechanisms here. And so we have participants complete 5 sessions within a 2-week period of time. The first session and the 5th session are when we have them undergoing fMRI during encoding. There's a 1-hour delay and then retrieval. I'm just going to focus on the encoding data today. In between, we have them come in for 3 sessions. The content of the sessions is the same. They practice learning information using either mnemonic strategies or spaced retrieval. Everything is very tightly matched. It's the intervention that differs. So here are some examples of how we've applied this. So there are a whole lot of different mnemonic strategies. And what we wanted to try and do is to boil it down to where we could teach patients a single approach that then they could apply to multiple types of information. Because I think it's problematic when we teach patients all sorts of different approaches, and then we're asking a cognitively impaired patient who may have some bradiphrenia to, in the moment, select, so first pull up all the different techniques that they could use, and then to select the one that's most appropriate for the situation at hand. So we've tried to make that step a little bit easier. And so what we do is have them use a feature, a reason, and then I don't show it here, but we encourage them to develop a mental image. And for us, that's the squishiest part because we don't have a good way of measuring that. I can't tell how good your picture in your head is. These are objectifiable. We can measure them. And so the idea here is that this ring is in between the sinks. And so the feature would be the sinks. A salient feature in the environment is the sinks. And the reason, it's not anything terribly complex, but you can see that because we're encouraging them to kind of talk it out, why would the ring be between the sinks? Well, it's because my hands are dirty and I need to wash them, but I know it'll fall down the sink if I wash them with the ring on. So that does that job of explicitly binding the object and the location. Same thing with the face and names. When we started this study, one of the big questions the reviewers had was, I don't even think MCI patients can learn to do this. This is going to fail. So we measured that. And actually, I don't show it here, but patients were able to develop their own strategies on about 75% of the trials. So they were very successful at doing that. And on each subsequent trial, what we would then do is show them the picture of the object separately and then an empty room here. In order, they had to tell us what was the feature, what was the reason, and then they could tell us the location. And we gave them hundreds of trials of doing this, again, integrating some of that rehearsal-based. But the goal was that we would fundamentally change the way in which they were processing this information. And on subsequent trials, after patients had developed their own cues, they did quite well. They were able to remember the feature, they remembered the reason, and they remembered the location. So we're actually showing that they were remembering more than what they would normally be trying to do, and they were doing it very well. I mentioned the spaced retrieval condition, which was very tightly matched on number of trials, session duration, and based on questionnaires that we gave patients after they finished the study on overall patient experience. So we didn't have any systematic bias in our study team. And what we had them do was remember the location of each object over progressively longer delays that started with immediate, so 0 second, and progressed all the way up to just over 2 minutes. And so when we looked at their memory test performance, this was highly successful in helping the patients learn the location of these objects. So everybody's well above 90%, right? Session 5 occurred 2 days after session 4. So session 4 was the final training trial. We sent them home 2 days later. They always came in and did session 5, which was our imaging and our outcome measure. And look at what happens. There's no difference at baseline. We know everybody was up above 90%. And after 2 days, we see that the strategy trained patients are doing really significantly better than those in the spaced retrieval group. And that those benefits persist at 1 month. And so not surprisingly, patients lose a lot of information over 1 month. But those in the strategy group perform significantly better than their baseline and significantly better than the spaced retrieval group, even 1 month later. When we looked at the patterns of activation, I'm going to show you so we included trained stimuli that they saw during the session as well as novel stimuli. I'm going to focus on the novel stimuli because I think that, again, supports the possibility of generalization. So when we looked at the post to pre, or the pre to post changes, we actually see reduced activation after training in those who received the spaced retrieval training. And so some of you, I'm sure, are scratching your head, well, they got better. Why are they showing less activation? This is consistent with repetition suppression effects that suggest increased processing efficiency. And so it's interesting to note that, again, we're seeing this even for novel stimuli. So patients were just getting more familiar with the task, and so they're, with that repetition, they're just requiring fewer neuronal resources. Where in the strategy group, we saw some areas of repetition suppression, but more areas of increase, and especially in some of these default mode network regions that we know are especially involved in learning and memory and are affected by Alzheimer's disease. And you can see the beta weight graphs are very clear. Subtracting or spaced retrieval showed reduced activation, and mnemonic strategy showed increased. And again, if we go back to our lateral frontal friend here, same thing. And so again, this suggests that the strategies were helping re-engage this top-down cognitive control mechanisms. And so remember I mentioned early on that the frontal parietal network interacts with the hippocampus. Very exciting. We saw a partial restoration of hippocampal activation in the head and the body of the left hippocampus. So we didn't fully restore hippocampal functioning, but we did see increases, and again, this was very specific to the strategy trained group. Even better, it replicates our earlier study with a smaller sample size, but using the same general methods. So this is, again, very encouraging and suggesting that we can have two different approaches that both result in at least transient memory test improvement and enhanced functioning, but in very different ways. And so the strategies appear to really re-engage. And we found the same general effect in a group of healthy older adults who were randomized to either strategies or to subtracting cue training. And subtracting cues, as many of you may know, we started with the face and the full name, and the participants on each trial just had to recall the name. So this kind of relies on that perceptual priming. And so you can see that then if there was an incorrect trial, we added letters in. If there was a correct trial, we subtracted additional letters until the participants were able to really recall the information. The strategy training was exactly the same as I just told you. Again, cognitively intact older adults, no difference at baseline. Strategies were superior, both after training and at 1 month. And there's our frontal parietal friend again. So you can see huge increases in lateral frontal parietal cortex, whereas there's generally more repetition suppression in the subtracting cue training. So again, we're seeing these effects in both cognitively intact older adults and in patients with MCI. So I'll wrap this section up by really just suggesting again that mnemonic strategies increase our depth of processing, help us better organize and contextualize information, and that they seem to really be re-engaging brain areas that we know should be engaged. Whereas rehearsal-based approaches can also enhance memory. Okay, so I got to move quick. So, via different mechanisms. So I want to very quickly focus on some of the work that we're doing in transcranial direct current stimulation. And I can go through this a little bit more, but really it's a neuromodulatory technique that allows us to play with the resting threshold of the resting membrane threshold and make neurons more or less likely to fire. And so previous meta-analyses have revealed a wonderful effect size. And this is a study that's probably 3 or 4 years old now. And you can see that any of us, I think, doing intervention work would love to have an effect size in this range. And so we've applied this just recently to spatial navigation. Again, another task that older adults and patients with MCI have a hard time with. And we know that there's a shift in how older adults, just with normal aging, process information. They rely less on spatial information and more on this egocentric, I go left, I go right approach. So we developed a task that does this, and I won't show you the video for time reasons, but really the video walks people through virtual environments, and we ask them to remember the location of each landmark and to form a mental map that integrates that spatial information. And when we compare the more spatial aspects of the task with a control egocentric task, we see these superior parietal areas as well as hippocampus. So again, this gives us a nice model to work from when we're examining TDCS-related changes. So what we did was use the same task, and we brought 22 healthy older adults and 20 patients with MCI in. They were randomized, double-blind. Half of them got active stimulation in the first session and then sham stimulation. The other half got sham first and then active. So we used a high-definition TDCS that gives us a little more control over where our current is going, and so we can try and focus a bit more on the right superior parietal lobe, again, to enhance the spatial processing. And during the sham session, this was very effective. We see that there is bilateral parietal involvement, just as we expected here. Okay, so again, we're replicating our results, suggesting that, yep, in fact, we're seeing it's doing what it should be doing. So then when we look at the differences between active and sham stimulation, we see that only the right superior parietal lobule, or the right hemisphere, showed increased bold signal. There was no difference in the left, despite it being active during the sham session. The magnitude of this bold signal change was, bordering on a large effect size relationship between the memory test score improvement, right? And at the group level, there was no significant change in memory test. And so we really then get down into some of the problems with TDCS where we know there's a lot of individual variability. And I think we have some methods in place that we'll be working on this week to try and understand this. And so these folks, this is wonderful, but I really am curious why these folks got worse and how do we identify those individuals? One of my students literally just last night emailed me and did some PPI analysis. And so we actually see in the cognitively intact older adults, we show reduced functional connectivity with this area as a result of active stimulation. So there was greater connectivity between this area and the insula and the thalamus, especially, which again goes back to some of those earlier studies suggesting that there's this anterior shift, and perhaps we're helping re-engage the local processing to make this better. But in MCI patients, we saw no such effect. So MCI patients, there's no difference between active and sham, at least locally. Downstream, we saw bilateral hippocampal increases that, as you can see, when we applied active stimulation, brought the bold signal in the hippocampus bilaterally up to levels of healthy, intact older adults. So again, suggesting a restorative mechanism. And so I think that's one of the things that we want to do is, again, put some seeds in the hippocampus and look at some of those PPI analyses to see if what about the hippocampus is changing, and really try and better understand why we didn't get the local effect, but we did get the downstream effect, or upstream, depending on which approach we take. So I think the bottom line with TDCS is that it appears beneficial when targeting brain regions that are associated with disease and the functional task at hand. We showed increases in TDCS relevant areas, and there are a lot of methodologic questions that my lab is currently looking at that, again, I'm happy to go into a lot of detail with. Just a very quick future direction self-plug here. We have ongoing study where we use TDCS, high definition TDCS, and pair it with mnemonic strategy training, again, trying to enhance that effect that I showed you earlier, and to enhance it, prolong it, and try and extend the range of people who benefit. So with that, I know I'm out of time, so I greatly appreciate your attention and the invitation to be here, and thank you again. Do you have
fabulous presentation? Are there maybe one quick question? Okay.
Thank you for this very interesting presentation. I don't know if my question is quick, but I'm going to try to make it quick. I think your results are very interesting because, to my knowledge, it's the first time that we could see such beautiful results about space retrievals and vanishing cues techniques that are recognized as very automatic, implicit type of memory strategies. So we tend to use them more in Alzheimer's disease than in normal control subjects, for example. And I've never seen a result like that before, so that's very exciting. And I would like to hear you maybe I heard your opinion about the fact that those types of memory strategies, in fact, may not be the best strategies
Perfect.
when you're MCI, but they may be perfect for persons that are already in Alzheimer's disease, you know, in the continuum.
And I promise I did not pay her to ask this question, but it's perfect. So that goes back to some of that individual variability that I alluded to at the start, right? Where in our 2012 paper and then in the data that I didn't get to, we actually see that the patients earlier in the disease course, so in the early MCI stage, however we kind of mushily define that, but patients who are closer to the normal end of the spectrum were the ones that really benefited from strategies. That benefit tended to taper off as the disease progressed, whether we used, I think it was the R-bands total score or the medial temporal lobe volumes. Whereas the spaced retrieval or in our earlier study, just pure repeated exposure, that had the same level of benefit regardless of disease severity. So I think you're absolutely right that, you know, at some point we need to shift our approach. But if we're dealing with somebody in kind of the subjective memory complaint in early stage, let's use strategies because it's a tool. They can apply it in their own life any way they see fit. Whereas then later on, we probably want to do specific things, help patients remember specific people's names and focus the training there. So wonderful question.
Yes, a very interesting discussion and very interesting presentation. I have just two small comments because we don't have much time. Regarding your mnemonic strategy, I think that this brings us back to the first part of this day, this morning, when we were talking about semantics, because I think that it is a mnemonic strategy, but it's in fact semantic processing that you are dealing with. And as we had just discussed this morning, semantics is something that is very well preserved in aging and even in MCI. So I think this shows the importance of semantics. And the second comment regarding the distant activations with regards to the TBCS stimulation, I think that a network approach would show you what's going on because complex behaviors are better expressed by networks. So you could see that probably your target area and the one that is activated belong to the same network. But I really love the kind of work you're doing and congratulations.
Great, thank you for those comments, and you're absolutely right. The network connectivity analyses, so we have resting state data that I also didn't show that are showing local changes, and then we're looking at network-wide changes as well. So those are all things ongoing, but that study ended relatively recently, and so we're just kind of sloshing through all the data. So wonderful comments, though. So again, I know I got the hook, so thank you so much.
Thank you. We'll pursue on the same type of topics for the three presentations, and of course I think that Benjamin really set the ground beautifully for the presentations that the other Benjamin and me, my name is not Benjamin, but amazing, so the woman version of the Benjamin here. So we all know that engaging in cognitively stimulating activities is associated with better late life cognition and a reduced risk of cognitive impairment and dementia. And for this reason, and also for the history, because there's a strong history on rehabilitation, there's a huge interest in the potential of cognitive training as a form of late life stimulation to increase cognition and provide some cognitive reserve to older adults. And it's interesting because in a recent consensus study report of the National Academy of Science, there has been a recommendation, one of the important recommendations, and that was given the highest priorities for research, was to promote research in the field of cognitive training because it was the area where there was most encouraging evidence regarding the possibility to prevent cognitive decline in older adults. So there's really lots of hope and interest for this field, but at the same time, as mentioned in this excerpt, the results is inconclusive, and in particular because we don't really know the mechanisms of action and whether that has an impact on the disease or that has a long-term impact. So there's still a lot of questions regarding cognitive training, and to fully bring the potential of this fabulous tool that we have, particularly for brain-impaired individuals or those who are at risk of brain disease, we really need to better understand the mechanisms underlying those effects. So just not looking at whether there has whether this brings improvement on focus or cognitive tests, but also really come with an understanding and models of how this modifies the brain and how this modifies behavior. And I believe that neuroimaging is a fabulous tool to this endeavor because it can really provide us with neurobiologically based training models. It of course informs on the cognitive and brain changes that are induced by this type of training. And when doing this, it can be used to guide selection and or construction of appropriate training. For example, if you want you may want to focus on training that restore the impaired function, or you could also want to rely on training that rather make use of unimpaired function or unimpaired regions. And this can be this information neuroimaging can provide information to guide you in these kinds of decisions. It can also be used and has been used to predict transfer because you can make prediction on the presence and or extent of transfer. For instance, whether the task that you're training or the function whether there's an overlap between the functions or the task that you are training and those that are involved in the transfer task, so that can provide you with some prediction as to whether you will expect transfer. But also there has been some people who have looked at regions that seem to be particularly important for transfer, so some kind of generate transfer regions. So I think that that's also another direction where neuroimaging can be quite important in the field of cognitive training. And I'm also very interested, and I know that Benjamin is as well, under the personalization of interventions. That is, neuroimaging can be used to identify the best responders. And again, there is some data showing that some neuroanatomical features or functional activation in different brain regions are associated with better response to particular training. And finally, neuroimaging can be a fabulous tool to identify as a surrogate markers of the pathology. So if you're interested in restoring functions or in pathological population, if you're interested in having an effect on diseases that have a very long evolution, you can use neuroimaging as surrogate markers, so as a quicker way to look at the effect on the pathology. So neuroimaging studies have asked a range of questions such as, does training produce structural changes? So do we see changes in volume, in cortical thickness? When using functional neuroimaging, you may want to know whether regions are more active or less active, something that Benjamin has looked at, or whether the recruited network is specialized. So is it a network that is typically involved in the task that the person is doing, or is the person using an alternative network, so relying on a task that is not typically used, relying on regions that are not typically used by the task that the person is completing, and also you may be interested in looking at whether changes occur in intact region, so that would be more which would suggest compensation, or in impaired regions. So are you actually changing the regions that is impaired in this population, and which would suggest restoration? So in a very brief review of the literature, Louis, Boller, and I, that we did a few a few years ago, we looked at the emerging literature that looked at use neuroimaging as a biomarker of cognitive training in older adults, persons with healthy aging and MCI. And we found that, unsurprisingly, structural imaging provides quite consistent and interesting findings with increased volume, cortical thickness, better connectivity, white matter integrity, some changes at the biochemical level also, and in terms of glucose metabolism. When looking at task-related activation, so using mostly fMRI but also PET, the results was quite inconsistent. We could see both increase and decrease activation in healthy aging. There was very few studies in MCI at that time. We saw that it was mostly increased activation, but there was no real pattern that emerged. And of course, as mentioned earlier, and I think you will see that this is really the take-home message of our three presentations, the training content and format and intensities are extremely varied, and so are population. And we came with models to suggest that, in fact, if you really want to have an understanding of the effect of cognitive training and all kinds of training, actually, you should take into account the fact that there are differences in terms of the characteristics of the training that will have an effect on activation change. There are also differences in terms of the characteristics of the individuals, which will also have an impact on how the type of changes that you will look at. And this has been the subject of many of our research effort in the lab over the last few years. And in this particular presentation, I will focus more on the characteristics of the training, and we will be interested in the opposition between strategic and practice effects and a training stage. So strategic and practice effect, I think that really speaks to the opposition between strategic and rehearsal training that Benjamin talked about earlier. So strategic training refers to learning strategy, or you teach people to complete the task in a way that is different. So it requires using different ways to do the task, and also it requires quite a lot of metacognition. So people have to consciously apply and learn and apply a new strategy. Benjamin talked a lot about that in memory. We've been interested also in using this terminology for attentional training as well, as you will see a little later. Whereas practice is, we use the term practice to refer to repeated, so repeating the task, or repeated the task with incremental practice, so in conditions where you gradually increase the difficulty of the task. And that has been mostly used with training that involves, for example, useful field of view, motor learning, working memory, but also memory, particularly with the work of Benjamin. So our hypothesis is that brain changes will depend highly on the processes engaged in by the training. So training content is not neutral. Compensatory training will induce cognitive changes that rely on preserved capacities, regions, to improve the impaired ones. So using imagery to improve associative memory, relying on metacognitive strategic behavior. And this kind, in this situation, what we expect essentially is increased recruitment or new recruitment in alternative regions and unimpaired regions. Whereas increased efficiency, where you optimize the impaired capacities, most often with repeated practice or incremental learning, well, you would mostly expect reduced activation. And that you would expect that in specialized regions, of course, so in regions that are engaged by the task prior to the training. Whereas restorative, if you're interested in restorative, if you expect restoration, then what you expect is a normalization of processes that were impaired. And instances of that is exactly what Benjamin presented, so improving associative or hippocampal function in MCI. And it means that you will be interested in specialized regions, so regions that are typically involved by the task, and that are impaired in this particular population. So as you see, there's a kind of a two-way interaction tool. You're interested in in looking at whether the regions are specialized or alternative ones, and whether they are impaired or intact, normally in the particular population. In our study, the first set of study that I'll present, we use the MEMO program. So this is a program that we've developed with Brigitte Gilbert and Francine Fontaine, and it's essentially a compensatory and strategy-based program. So the people will come for a few sessions, 6 to 8 sessions. They come in small groups, and they learn a range of imagery-based or semantic elaboration strategies, and you have them here. And it's an example where people will be provided with a range of strategies. So it's not focused on one strategy, but in this particular study. So for instance, they would learn the method of LOCI, where people have to associate items to locations in a familiar environment, or they will learn face name association by looking at the person, finding a feature, and making a funny association between the name of the person and this particular feature. So here is André. André is a photographer here, is always in my presentation, so he's perhaps here in the room. But in our group, his name is Deschamps, so field, and this is a kind of association that we teach people to do. So make a funny association between the name and a feature of the person. We just this paper will come out in a few days or weeks, so it's a work that showed that this kind of training is efficient and it's durable. Here we recruited a little more than 140 MCI from Quebec and Montreal, and they were randomized to MEMO and psychosocial intervention or waitlist, and the psychosocial and cognitive training were provided in very similar format, and we looked at the effect post-training 3 months and 6 months later. And what essentially we saw is that this is a very efficient training. So people improve their delayed memory. So you have here performance on a composite delayed memory score. So you can see here that the effect is present post-training, and it's durable, the effect at 3 months later and 6 months later on delayed memory composite score. And that's interesting because delayed memory is really a very sensitive indicator of MCI and of progression toward dementia. In terms of generalization, we also found that people report using strategy. So they increase their repertoire of strategy in their daily life. So we believe that there is some kind of this generalization, at least of the in terms of using, knowing and using the strategy in their daily life. So we were interested in looking at what this kind of training has, or the effect that this kind of training has on the brain. And this is a paper that was published in 2011. It's not the same group as the one I just showed you. It's a different group, but these are people with MCI. They were also healthy controls in that study, and it's a repeated design in the sense that people are their own controls. There's a first fMRI, then a wait. So here they do just wait, and then we repeat the fMRI, and then they receive the training, and we do the post. So here, this comparison allows us to look at the effect of repetition. Essentially, what we found was decreased activation, and we can now compare the effect of the repetition, take out the effect of repetition by comparing the pre to the post. So it's a cheap kind of design if you don't have much money. So essentially what we did find, so here, remember that we use this MEMO program. People were trained on a range of semantic and visual imagery strategy. So strategy-based training, lots of metacognition. So we expect essentially increased activation or new activation in regions that are engaged by the training. And this is exactly what we found. That is, these are the regions, this is the activation related to post-training. So it's post minus pre-2. It's in the condition of encoding. So I don't show you here the retrieval. And what we see essentially are increased activation and increased activation in new regions. That is, these regions were not active prior to training. We found increase in the superior, in the left superior temporal lobe and in the parietal cortex, inferior parietal lobe right hemisphere. And we also find regions in the left thalamus, putamen, and global pallidus. And that's interesting because what we find in terms of activation change is essentially things that are related to semantics, to visual imagery, and procedural memory. So in a sense, it's interesting because these people are really learning a new procedure, and as most of these activation are new activation, apart from the one in the left superior temporal gyrus. And in terms of intact versus impaired function, essentially those regions were intact. That is, when we compare MCI persons to healthy controls before the training, what we see is that the regions that are newly engaged or that are increased are regions that were actually intact in those individuals, except for this one. And it really makes sense with our strategy, because what we wanted in the training was to help people promote episodic memory, associative memory using capacities that we believe are less impaired, so semantic, visual imagery, that kind of things. So strategic training of episodic memory increases activation in a new alternative network, mostly of intact regions, and those regions are involved in procedural learning, visual imagery, semantic elaboration, and they're really the active ingredients that we have included in the training. So they're consistent with the type of training that we've devised, and they're also consistent with the fact that these people are actually engaging new strategies, new compensatory strategies. But in this first study, we didn't actually compare practice training as Benjamin elegantly did. We did that in a further study. This is in healthy older adults. And here we were really interested in comparing strategic and practice training. So we devised this intervention. Well, it's actually, we used an intervention that has been made very popular by the Kramer's group, and Louis Perez has used it a lot as well. So it's an attentional training program where people are taught to better make use of their attention in dual tasking condition. And here they will do two things at the same time, and at the same time, an equation task, if you want. So is D 2 letters away from B? The answer is yes. And at the same time as they solve these equations that are quite complex, they have to do a visual detection task. So they have to press on the key each time this comes red. And what is really the training component in this task is that they will be taught to vary their task allocation. So for a few trials, they will say, okay, you see, if you have, let's say you have 10 inches of attention, place 8 inches of your attention on the equation task, and only 2 here. And on some other trials, they will be asked to do the reverse, that is, pay more attention to this one than to this one. So they will do that repeatedly. And what has been found is that this is very powerful to increase the sense that you can have a control on your attention, and to increase your ability to actively control your focus of attention. So if you want to apply that to a real life activity, just imagine yourself in a car, you're discussing with your husband, and you're very intense in the conversation, and suddenly you end up on the highway and there's an accident and you have to pay close attention to the highway. So you can pay attention to your conversation, but at some point you need to change your focus of attention, and we do that all the time. in our environment. We're always in conditions of divided attention. You're writing while you're listening to me. And in some occasions, we need to balance the priority. And that's what we teach people to do, because we found, I mean, there's some evidence that older adults have a hard time to do that kind of emphasis, very active emphasis control. So here we had therefore these two, and so that was our strategic training, and we also had a repeated practice. And here people would just do these two individually, repeatedly. And we also have a condition that I don't show today, because the results were a little mushy, but where they actually do the two things at the same time, but they don't flexibly modify the emphasis. Here we really focus on the distinction between doing this, variable allocation, and repeated practice of individual tasks. And what we found is that the two groups were more rapid, of course, on the equation task. They were practicing the task, so they were more, they were better at it. But only the variable training improved the capacity to divide their attention. So here is a dual task cost. So the higher it is, and the more difficult it is for you to do the two tasks at the same time. And what we see is that those in the variable training drastically reduce their dual task cost, but also they were better able to actively modify their focus of attention, which makes sense because that's what we taught them to do. And of course, it means that when you ask them to focus more on one task, the cost is lower than when you ask them to focus more on the other task, then the cost increase. So as you see here, after the intervention, there was the dual task cost was much influenced by which task you were supposed to prioritize. How about brain changes? Well, interestingly, what we did find that variable training engaged a new activation in a region that is very similar to the region that Stoss has attributed to metacognition. So it's a frontal lesion, it's area 10, it's a region that has been related to multitasking, and it's increased activation. So we see that this condition, along with our hypothesis, increased activation in critical regions for metacognition and dual tasking, whereas repeated practice essentially reduced activation. And it reduced activation in the working memory regions. And it makes sense because this equation task, that was during the equation condition, not during the dual task condition. And this equation task is really a working memory task. So we had them practice this working memory. They are more efficient. And we see here again that it makes a huge difference, the type of intervention that you provide to individuals. So it's important because as clinicians and as researchers, not all interventions are the same. So depending on the type of change you want to promote, you will have very different, you'll have to select different types of intervention. Now, I don't know how long I have. 5? Okay. But I just want to mention very rapidly this last study, because it's a study from Bianca Bier. I don't think she could be here today, but she's going to defend her thesis very soon. And she's really been a very, very wonderful collaborator in this set of studies. And she looked at, and we were interested in looking at the buildup of intervention effects. Because people use usually 2 points, and they looked at pre and post, but people are doing lots of things during the training. So if you're doing 15 hours of training, 25 hours of training, 8 hours of training, do you really expect that it's all going linearly? Probably not. And we have the chance here of having a group of Julien Doyon and Habib Ben Ali who are very interested in procedural learning. And they taught us that there's actually qualitative changes as people learn procedures, so as people learn motor procedures. So we thought, probably there's also something similar with that. And as a cognitive training specialist, we should perhaps start to look at how activation change build up during training, because there might be differences in terms of in terms of strategies. So people perhaps engage very active strategies at the beginning of the training, but at some point they automatize it. They get better at it. And that will involve other brain regions. So here we were. It was our first, and we are doing we're just starting a set of experiment on these questions. But here was our first study that looked at this aspect with a 3-point study. So these were 30 older adults. They were randomized to variable or repeated practice. So it's the type of attentional training that I described to you earlier. So they were trained during 8 one-hour sessions, except that here, rather than having only a pre and a post, we had a middle train. We also did an fMRI in the middle, so we could look at whether there would be rapid changes or perhaps changes in terms of the qualitative processes that are engaged. And this, because we're starting to look at the data, and here what I show you essentially is the areas where there was an interaction between time and a condition. Okay, so that's very important because there's a lot of changes that occur that are not necessarily related to time, so they are just linear. Here we were interested in changes that depend on time. So the areas where there is an interaction with time, an effect of time. So essentially, and what we found is very interesting in that this is the variable training, remember, where people will learn to vary their focus of attention. And we did find quite a large number of regions with this very exact pattern. So very rapid increase of activation and then some kind of leveling. So, but look at that, this is behavior. It's interesting because we see that at the behavioral level we have a very similar things, but things continue to improve though. It continues, so that's the cost. So costs diminish very rapidly, and then there's some kind of a stabilization, but there seems to be like a slower learning. And in terms of the brain activation, same pattern, very active increase. And let me just show you this. This is an area that we found in this other experiment. So we do see this area of meta control that's increased, and then but there's also some areas in the parietal lobe and in the motor region. So very interesting because what we see is in fact a leveling of the activation, whereas performance seems to continue to increase. Repeated practice, very strange data. We were very puzzled by the finding because what we do find, because we were expecting decreased activation here. But and remember that in our previous experiment, what we did was a scan here and a scan here, and there was decreased activation. Here we see that there are regions where there's actually increased activation, and this is in the condition of equation. And what we see is that at the beginning of the training, there are some regions that are increased by the training. So it's not true that repeated practice will, in all regions, necessarily only diminish or be associated with increased efficiency. There seems to be also regions that are newly engaged by the training. So to finish, because Benjamin is telling me that I'm over, what have we learned here? Well, not all training have the same effect of the brain. So it's not because there's 2 pills that it has the same effect. Can have the active ingredient can be extremely different. So we saw that the active ingredient in different training are extremely different. It's a very important message to journalists, people, because people think that this training was found efficient, so it means that all the training will have the same effect. Not necessarily. So as you say, content matter, content is not neutral. There is differences in terms of behavior, but there's huge differences in terms of the effect of the brain. And we also found that, in fact, the predictions make sense. So we can see a coherent pattern with learning strategies, increasing activation in alternative regions, with compensation, and repeated practice reducing activation, suggesting efficiency. And learning stage is critical, but we don't know much about that, so it should be better examined. I have no real, I mean, there's probably an interaction also with the type of training, but also with the participants that you include. So some participants may need more time before they switch from the strategic to the efficiency stage. And I just want to thank my team, trainees, but also assistants, particularly Samira, she's been so important, Benjamin, Bianca, Brigitte, who's been a collaborator for many years, and Nathalie, with whom we start to do things. So thank you for your attention. Do we have time for questions? No? Okay.
What I will propose is that we have just time for question for the three of us at the end of the talk, because I will continue to present the data that are really close to what have already been presented. So I'm very glad to present today the work that I realized in Sylvie Belleville lab here in the CRUGM. All the research was done here with Emily Ouellet, that will be the next doctor of psychology in maybe soon also. So I will go rapidly on this notion, because Benjamin and Sylvie have present really well all of that. I will talk about neural mechanism implicate in cognitive training, but more in metacognitive training and strategic learning. And we know that what has been presented, and here the work of that Benjamin present, that he could, after training with mnemonic strategy, you could see restoration. And particular here, what is interesting is when you look in MCI population after training, they activate like the LC control, like they do when they are not trained. It's an example of restoration. And what Sylvie has presented just before, it's also in MCI population, teaching different mnemonic strategies, activation of new regions that support that, because with this kind of mnemonics there is other cognitive functions that are preserved, that are recruited by this kind of mnemonics, and then we saw temporal and parietal regions. So what is interesting is with a model proposed by Sylvie is that part of the brain pattern of changes will come from the training characteristic, but I will focus also on the individual characteristic that will modulate the pattern of brain changes. The population that I was interested in was the individual with subjective cognitive decline, because this population at risk of Alzheimer's disease, and the percentage of progression is 7 to 8 that convert per year to MCI or dementia. So this population, what is important to know that after evaluation, there is no objective cognitive deficit, but they report self-report perception of a recent and persistent decline in memory or cognition. So what is important, they say that they have a problem in the memory, they perceive a change, and they worry about that. We know that in very early course in the Alzheimer's disease, there is an alteration of memory encoding. And in the context of rehabilitation, providing cognitive training based on memory strategy that enrich encoding will be a solution. So But we know also that in cognitive aging, normal cognitive aging, we know there is a decrease in attentional resources that will make it more difficult to encode new information, especially in, for instance, noisy environment or dual tasking or stuff like that. So the question is, in this study, if age has an impact on the response to cognitive training in that population at risk of AD. So our objective was first to evaluate the neural mechanism implicated in the cognitive training based on memory strategy in this population. The second objective was to evaluate if cognitive training can restore the effect of age on memory functioning in this population. And third was to evaluate if age has an impact on the behavioral and neurophysiological response to cognitive training. So we recruit 29 individuals with SCD. And what is important to note here is the age. They are from 54 to 84, that the range is huge. And they were well educated. The training was the method of LOCI. So Sylvie has talked about it, and Benjamin also. It's about binding an item to remember with a familiar location. So you will use mental imagery and mental routes that you will create, and then you can find, using your mental route of a familiar place, the item that you have to remember. After 6 one-hour training, we present the data, but first what we do is that we use fMRI to evaluate the neurophysiological changes, and after 3 sessions and after post-training. So we have 3 time points, and we use a simple encoding task of a list of words. So here the result at the beginning, before training, what we observe at the full recall task at behavioral level, that there is no difference between participants if we split by the median of age, that is 65, the population, so in 2 groups. But interesting, in the whole group, we observe the pattern of encoding neural network that recruit mostly the visual, the occipital cortex, but also involve frontal and temporal cortex. So what we observe at the beginning, it's a negative correlation between encoding related activation and age. So what you see here is that there is less brain activity in the prefrontal cortex in the older participants. They recruit less these regions. And these results had already been published and shown in the field. But what is interesting in our training is that after training these particular regions, you can see there that there is no difference between the younger participants at mid-training in these regions. They start to be not different, that there is no difference between the 2 groups. So that was for the first part of the results. Now we will look at the effect of training from mid to pre. And then when we separate between the 2 groups, what we observe that both groups increase at behavioral level, but the younger benefit more. They increase more the improvement. Here what you can see, it's the difference between mid and pre activation at the encoding. And what we observe that new regions were recruited, the posterior cingulate and the right precuneus. And interestingly, when we look at the effect of age from mid to pre, what we observe is that there is more brain activity in the left superior temporal and post-central gyri in the older participant. So that was a little surprising. I will discuss about that. So at mid, the older activate more this region than the younger. Second, now we will look at the effect from mid to post, done after 3 more sessions of memory. And what we observe that they continue to, the younger continue to increase their performance while the older participants show a plateau. So here is the result from pre to post. So it's really the same. There is no more additional recruitment from mid to post. The activation that the new regions that were activated at mid continue to be activated at post. But interestingly, when we look at the effect of age on the encoding neural from mid to post, what we observe is there is more brain activity in the left inferior and middle occipital gyri for the younger participants. So the younger at the post-training start to recruit these particular regions, and they continue to improve their performance. That you have to keep in mind. I will discuss about that. So first, after this kind of strategic learning memory training, both groups improve their performance on memory, and the younger perform better than the oldest and continue to increase their performance at post. What is interesting at neurophysiological level is regarding the whole group. There is additional posterior regions that were recruited after training. Those regions are associated with mental imagery. So it's interesting because it can be a compensatory mechanism that are active. Another thing important is that we show that there is no more impact of age on the right prefrontal cortex after training, both on younger and older adults who recruit this region during encoding. You remember at the beginning, the older do not recruit this particular region, so it suggests restorative mechanism, because by recruiting this region, they improve their performance. Considering our third objective, in the oldest participant at mid, what we observe is additional recruitment of temporal regions that are associative with phonemic representation of words and the use of verbal mental strategy that is consistent, that are not really apply the strategies that they learn. They're doing something more like verbal, like try to repeat it and repeat the word in their mind, but they are not really applying the visuospatial strategy. And what we observe is that the younger participants at the post-training activate additional region in the posterior that know to be involved in mental imagery, visuospatial representation, and the use of the strategy. So it means that at the end of the training, younger continue to perform and start to begin continue to be good to use the visuospatial strategy. So to conclude, what is interesting and in the model of cognitive brain changes that proposed Sylvie is that the individual characteristics are really important to predict the pattern of brain changes, and age will be could modulate the behavioral and neurofunctional response to training in this particular population. Thank you for your attention.
We have time for questions. Or maybe for questions for the three of us.
Yeah, would be nice.
Because Benjamin was very good at recuperating the time. Thank you, Benjamin. Benjamin?
For the great presentation to all three of you. I'm wondering if the subjective effort and motivation in these training programs are taken into account, because you could think of a performance level that is stable or increase in processes efficiency with no change in behavioral performance, but reduced perceived effort and actually less energy devoted to performing to the same level.
Well, I think that's what efficiency would refer to. So I mean, it comes from you, I'm not surprised. It's true that we don't really have scales on effort, but we do find sometimes activation that seem to suggest that there is effort. So I think that makes sense. It comes into the equation. So I don't know if you take this into account.
Not yet. So, thanks. I mean, great point. I mean, we did include questionnaires in that study that I showed you that now I'll have to go back and look at, where we asked the participants how difficult was this, and so we kind of took the metacognitive. I'm a little leery of those data though, because we know that metacognition is impaired in many individuals with MCI, and then especially in Alzheimer's. So, I'm not sure. I haven't looked at those data. I think it's a great point, and it would be interesting to compare within the patterns of change. But recognizing the known limitations of those type of measures is something that we'd also have to grapple with.
Maybe talk about the motivation, because it's always a concern in cognitive training. And what was really nice in this study, surprisingly, is that when they understand the training, the participants, they were older, but they can use it at home. They can use it in real life, and they can bring the strategy at home. So finally, they were all really implicated, and they want to continue because they have a real benefit in their own life. So that was really nice for us, because we have nobody that stopped the training. So that's really nice in this kind of, but also that we have to keep in mind that for next research, it's really important for motivation people to be involved in, that they will have a real benefit for them to participate to research. So that's really important, and it's also important for us, because you have no participant that gone during the study. Thank you.
Anna?
Okay, so I'll try to be very brief. Very, very interesting work. Concerning the fact that there is a learning stage effect on activations, and there are some areas that plateau while others perform differently. Just one idea, because we saw this in studies on second language learning, and what we see is that depending on the learning phase, you have a larger engagement of the executive control system, which, by the way, are the areas that you see that peak at the beginning and they then plateau. But when people attain a certain level of performance, this circuit tends to disengage. So you don't, it plateaus in terms of activation. And maybe this is showing you that there's different stages in the learning process that you're trying to highlight. One which is more, let's say, depending on executive control, and another one that is more refining aspects of the learning. So maybe a way to look at it could be.
Well, we actually, we entered the interaction term. So we didn't have a fine-tuned, top-down, ROE approach to the data. But so it's we could do like you say, so perhaps have a more directed approach. So we essentially saw these plateaux, except in the repeated practice. What we saw is perhaps similar to what, because we saw things that would suggest that first they find it difficult, and then it's okay. I mean, they've had enough practice. So I think that this inverse U shape that we found seemed to be related to a kind of a difficulty type of thing, effort.
Recruitment of the executive control circuit reflects effort.
Yeah.
And depending, as you say, depending on the type of task and stimuli that you use, you may be playing this effort.
Yeah. Well, in our particular, in the particular Bianca study, it's an executive control training. So we are expecting that they will engage, but not because it's difficult, but because they are actually imposing their metacognition control on the task. So that would be a good thing to do. You want them to engage at the frontal level.
Get good enough.
Yeah, and then it's level. It's plateaus.
I agree also with you that if we stop the study that we have done, we never seen that the younger, older adults continue to recruit new regions to better perform. So that's interesting that maybe in the course of learning that there is differential processes that can be recruited, and we have to know more about that. And maybe looking at the learning literature in younger maybe help to understand the differential processes that are recruited in cognitive training. Thank you.
One last question, perhaps?
Yes, this is actually pretty simple. I really enjoyed listening to all the talks, but this the subjective cognitive decline group I think is really interesting. It's not a group I was aware of. And I'm just wondering if a lot of this discussion of motivation relates to the fact that these folks are self-defining as having cognitive decline and potentially more motivated to engage in these ways. So I'm just sort of wondering in a broader sense, how generalizable do you think these folks are to other kind of populations we care about? And I'm wondering to what degree you think that they're a kind of special group or just a really ideal group to study because they really have a sort of this meta-awareness of their own current cognitive state.
They're probably certainly a heterogeneous group, that we have to be aware of that. And that's a discussion we've had because the older ones are perhaps more pre-MCI. So there might be, within this SCD, there are probably pre-MCI people and people who are more worried, and they will not. But the MCI are interesting also because the MCI progress a lot. I don't know your rate of progression. Our rate of progression is huge. Yeah. So, I mean, MCI are very interesting. SCD, we've been very interested lately on this particular group because they are very easy to recruit. They're probably very early. If we think that Alzheimer's disease is running over 20 years, yeah. MCI is like 3 years, 4 years. Right. They've all progressed. It's still very late in the process. Yeah.
Sorry. Just to go back to that point, I think that each of the populations, I mean, including patients with frank dementia at this point, are highly motivated. Yeah. And so I think that there's a lot of dissatisfaction with the notion of, okay, well, here's one of our existing pharmacologic agents that maybe if you can tolerate the side effects, it will maintain where you're currently at. So patients, their families are very, very motivated across the disease spectrum. I mean, coming back to one of the things that we do, I think is just good clinical trial practice, is that we encourage patients not to participate if they can't finish the trial, right, so that we can minimize dropout. We've only had a couple of people, and just subjectively, I think those are the people with very poor insight that say, oh, there's nothing wrong, I don't need to do this. You know, whereas the ones that have better insight, I think, are more likely to be engaged and can recognize the problem. And so I'll have to go back and look at our refusal rate, but I think it's pretty nominal.
Mm-hmm. Yeah, I just really like this, and I like the fact that you brought up this issue of motivation, because I think it is something that hasn't come into the room. Yeah. And as I'm thinking about the work that I've done with folks with depression or fibromyalgia and pain disorder, I mean that sense of I really want to get better. And then I just throw in, there's also this sense of sort of fait accompli, right? It's going to happen and I'm doomed and there's not much I can do. And I really do think I know in my own work, I haven't really thought about sort of that motivational state very much, and I think it's a really important.
I just want to add one point because I see Aline there. We're launching now a study with CCNA. We're interested in people with low motivation. Yeah. We're interested in people who don't participate to our research. So we want to go and pick up people in Saint-Henri, so people who are not the typical, very motivated, empowered, you know, less reserve, less education perhaps. This is a very important group to target as researcher, and then if we want to have an impact in the population.
That's a very good point. Thank you.
So I think we can stop now. There's lunch upstairs, and this afternoon we're really, I think this really makes sense, the 3 sessions today, because in this afternoon we'll talk about bilingualism, so like a natural kind of cognitive training, if you wish. Thank you.